A.J. Khandra graduated from the NTR University of Health Sciences in India. He completed an internal medicine residency at the State University of Buffalo in Buffalo, New York, and he then did a hematology and oncology fellowship at Thomas Jefferson University in Philadelphia. Dr. Khandra has clinical research interests and clinical practicing interests in head and neck cancer and lung cancers. Dr. A.J. Khandra will present innovations in immunotherapy, advancing treatments in head and neck cancer. Dr. Khandra.
Thank you so much. Hello, good morning all, and I would like to thank Dr. Flynn, Dr. Ham for giving me this opportunity and all the organizers with Norton to give me this opportunity to present on head and neck updates. This year was a very exciting year for head and neck. We have 3 practice-changing studies which I would like to show. I'll start with a brief introduction. These are my disclosures. Brief introduction of the basic treatments, the primary treatments, and then slowly give the context for how these the new data fits in. So the 2 definitive modalities, basically in head and neck cancer, so surgery and radiation therapy. And this modality depends on the anatomic side, functional expectations. Oral cavity, it's mostly surgery, and then you do adjuvant therapies based on the risk. Oropharynx, mostly radiation therapy, chemoradiation therapy, and minimally invasive surgeries in select cases with TORS. Nasopharynx, mostly radiation, chemoradiation, or induction chemo at higher stages. For hypopharynx, we use radiation or chemoradiation. And again, there are some selective cases where they're using surgery in these cases. As far as larynx, total laryngectomy if you can't salvage the function, otherwise radiation and radiation chemo. Surgeries, so basically sinus tumors, you can do either surgery or radiation depending on the extent of the tumor. So as far as unresectable patients, concurrent chemoradiation therapy remains the standard of care for locally advanced cancers. And this is based on a very large meta-analysis called McKinsey, which had 17,000 patients. And cisplatin is basically the treatment of choice. As far as HPV-related oropharynx, this is a very distinct entity with a very good prognosis. But we have to watch the treatment-related sequelae, and we need, there's a role for de-escalation. We have the ECOG 3311 study that really helped in reducing the radiation doses in select patients. HPV vaccinations are going to make a very big difference. In the next 20 years, you'll see a big drop in the incidence of oropharynx cancers. So going to the metastatic space, we have our first-line treatment choice is pembrolizumab or alone or in combination with chemotherapy based on the KEYNOTE-048 trial. And again, there's a role for patient selection based on the CPS. PD-L1 positive tumors tend to respond better to respond better with the PD-L1 inhibitors. In CPS 20 and higher population, pembro seems to be as good as chemo plus pembro. So you can certainly use it as a single agent. And the second choice regimen is extreme trial regimen, which use cetuximab in combination with chemo. And then you had second-line treatments where patients did not receive immunotherapy as first line. You could offer them single-agent treatments, and then cetuximab and chemotherapies. I'll just show a subset analysis from the KEYNOTE-048 trial, and you see on the top 2 slides are CPS greater than 20 population, and you see the curves separate well and equally. To the left, you're seeing chemo plus pembro. To the right, you're seeing pembro alone, and the hazard ratios are pretty much similar. And that separation is a little less in the bottom slides, which are CPS over 20. So basically all comers over 1, but still single agent pembro can still be given, and you could avoid some of the toxicities from chemo. So we'll go to the resectable disease, high-risk resectable disease, standard of care was once adjuvant radiation therapy, and we're talking about 2 decades past, 20, 25 years. So the question was asked, does adding chemotherapy to radiation improve outcomes? And in 2004, we had 2 pivotal trials that tried to answer this question. One is the EORTC 22931 and the RTOG 9501. And they had resectable squamous cell cancer patients who had surgery, and based on high-risk features, they were randomized to cisplatin radiation versus radiation alone. And there was some difference in the high-risk criteria between these 2 studies, and but extracapsular extension and positive margins are the most common things for both these trials. And to our surprise, one trial was positive, the other was negative. The EORTC had survival benefit with a hazard ratio in the 0.7s, and you had the p-value 0.02. But the RTOG trial was not statistically significant for survival. So they did a comparative analysis, post-hoc pooled analysis, and what was found is the patients with the extracapsular extension and positive margins are the ones who seem to benefit in both of these trials. And they had several analyses thereafter. And so to this day, basically, we were offering radiation and chemo only to the patients with positive margins and extracapsular extension. That's the practice for the last 2 decades. But unfortunately, what we realized is despite that there's 40 to 45% of these patients with high-risk disease experience recurrences either locally or at distant sites. So there is an unmet clinical need, and we had to look for something better. As you all know, we just discussed PD-L1 inhibitors have a very established role in recurrent and metastatic disease, and we need to bring this into early stage. And can we add them to adjuvant, neoadjuvant, and concurrent therapy? And so basically that sets the stage for this year's 3 important trials that have been practice changing. I would like to just say, we had trials before, including a Keynote trial, Javelin trial, and trial with Atezo. They were all negative, but the designs were a little different. So let's jump into Nivo post-op, which is a GOTEC trial, randomized multicenter open label phase 3 trial. Here we are testing adding nivolumab to standard of care in high-risk patients. And this is the design, and the patients were less than 75. Cancers were from oropharynx, larynx, hypopharynx. The trial included 680 patients. They had to have complete macroscopic surgical resection, and they were randomized 1-to-1. The top arm is the experimental arm receiving nivolumab 240 milligrams, 1 dose followed by 3 doses with cisplatin radiation, and then followed by another about 6 months of nivolumab, 6 doses. And that was compared with cisplatin radiation. And here are the high-risk features that were included: extracapsular extension, positive margins. They also included multiple PNI with perineural invasion and patients with greater than or equal to 4 lymph nodes. Here's the baseline characteristics, and median age was close to 60. Majority were male. Majority of the patients were smokers. Majority of the cancers were oral cavity, as this is a surgical disease, and that's the population we are looking at. And then we had patients from hypopharynx, larynx, and oropharynx. And to the right, you're seeing majority of the high-risk pathological features in the middle row is extracapsular extension or positive margins. That's about 90%, and the other risk factors were about 10%. Close to 90% of the patients had PD-L1 positive disease. So disease-free survival curves, you see right here, we're seeing a substantial separation of the curves. The top curve represents the group with nivolumab, and at 3 years, you're looking at 62.1 versus 42.5%, with the improvement in the hazard ratio being 0.76. The median numbers were, so 3-year disease-free survival was 63.1 versus 52.15. There should be a median overall survival. Maybe it's at the next slide. So majority of the disease-free survival events were improvements in the locoregional, plus some patients with both locoregional and distant disease. So the benefit seems to be more in the locoregional area versus the distant in this particular trial. And here you see the subgroup analysis, and you see benefit in most of the subgroups, specifically in the oral cavity and non-oropharynx. We are seeing more substantial benefits, less benefit in the P16 positive patients. So overall survival, we see the two curves separating, but this is not statistically significant yet because the data is immature, waiting for more events. But there's definitely a trend. And as far as toxicities, there wasn't much difference between the two arms. Some minimal increase in the toxicities with nivolumab. As far as all-grade toxicities, 33.3 versus 30.6%. So a summary of the trial is nivolumab added to standard of care cisplatin radiation therapy in high-risk resected disease, improved DFS with a hazard ratio of 0.76 without any major increase in toxicities. Overall survival data is still mature. This is a new standard of care in high-risk resected disease, and it is practice changing. This study was presented in ASCO 2025 plenary session. So we'll move on to the Keynote 689 study. This is investigating neoadjuvant and adjuvant pembrolizumab with the standard of care in resectable, locally advanced head and neck cancers. This is a phase 3 trial, open label, and trial included about 714 patients, and it included patients with resectable disease. They were randomized 1-to-1 into 2 arms. The top arm received pembrolizumab 2 doses before surgery, and after surgery, those patients who had high-risk disease were given both cisplatin radiation in both the arms, but the study arm received pembrolizumab 3 doses along with radiation, and then followed by another 12 cycles of pembrolizumab. Primary event-free survival was primary endpoint was EFS, and then secondary endpoints were major pathological responses. Complete PCRs were also looked at, and safety as well as distant metastases-free survival and locoregional failures were also the exploratory endpoints. And I think we went over this. So EFS, here's the EFS curves, and you see the group that received pembrolizumab did substantially well, 57.6 versus 46.4%. Hazard ratio 0.73, statistically significant. And this is all populations. Now, when you look at the subgroups, CPS over 10 versus CPS over 1 population, you see they were benefiting both the groups, and with some difference in the hazard ratio, 0.66 versus 0.7. The trial had actually very few, about only 27 patients with CPS 0, so just a note right there. So pathological response rates, median pathological response the major pathological responses. So if you look at CPS greater than 1 or equal population, that was 34, and most of the major pathological responses were in the CPS over 10 group. And there were no pathological responses noted in the CPS 0 group. And you look down, that's the PCR rates. Only about 11 patients in the entire population had PCR, and about 10 of them were from the CPS greater than 10 population. So clearly you see that the high scores are the ones who are getting responses. And this is the distant metastasis-free survival. This is where the predominant benefit was seen in terms of follow-up, more than loco-regional, it was distant metastasis-free survival, hazard ratio 0.71. So as far as toxicities in the middle table, all group, any grade toxicity, 81.4 versus 81.9. As far as immune-mediated side effects, 43 versus 10.2%. So here are the conclusions. So perioperative pembro added to standard of care significantly improved EFS, pathological responses, and was associated with longer disease, distant metastases-free survival. Rates of locoregional failure was similar between the two groups, but distant metastases rates were substantially lower. There was no, adding pembro did not negatively impact the surgical completion rates. They're exactly similar. There was no added substantial toxicity. And if you look, the major pathological responses were confined to the PD-L1 positive patients. So FDA gave approval in June this year, and it was limited to the patients who had a CPS score greater than 1. And this is the new standard of care and practice changing, not just for the medical oncologists, but for the surgeons, because now they're now stopping and seeing which patients would benefit from neoadjuvant, and they get the 2 doses of pembro and then go for surgery. So I'll quickly move on to the skin cancer trials, cutaneous squamous cell cancer. Adjuvant cemiplimab was compared with placebo in high-risk cutaneous squamous cell cancers. As you know, in this disease, surgery is the mainstay of treatment, and that cures 90% of the patients. However, there's a subset of patients who tend to have recurrences despite getting adjuvant radiation therapy, and we need to improve the outcomes in that particular population. The CPOST study was presented this year. It's a randomized phase 3 double-blind placebo-controlled trial. Total 415 patients with about 209 assigned to cemiplimab versus 206 to placebo. And the inclusion criteria were local or regional cutaneous squamous cell carcinomas. And after surgical resection and post-operative radiation, they were randomized. And those patients who had high-risk features are the ones who were looked at. And there you see the bottom down, you see the high-risk features, which include nodal features and some non-nodal features. Extracapsular extension with at least 1 lymph node greater than 20 millimeters was the most common high-risk feature in the study. And they also had patients with 3 involved lymph nodes. Non-nodal features include in-transit metastases, T4 lesion with bone invasion, with skull base invasion, perineural invasion, or locally recurrent tumor with greater than 1 additional risk factors. Just if you're wondering why we're looking at skin cancer, 80% of the skin cancers are confined to the head and neck. That's why we see this cancer a lot in head and neck. So I'll just skip in. So this is a design for the trial. The first box, patients had surgery, and if they had high-risk features, they got radiation therapy. And at that point, they were randomized to cemiplimab versus placebo. Cemiplimab was started at every 3 weeks for 12 weeks. However, they modified the trial a little bit, and they gave the later part of the treatment every 6 weeks at a higher dose. And there was also a follow-up, part 2 of the trial. We're not going to look at that. That's still ongoing. That's for recurrent disease. Primary disease endpoint was disease-free survival. And again, these are the risk factors. I put a slide there so you can look at it. We talked about the eligibility criteria, and patients with heme malignancies except stable CLL were excluded. CLL is one place where you see a lot of skin cancers. Okay. Let me just see. I'm going to skip some of the slides in interest of time here. So, like I said, the highest risk, most common risk factor was extracapsular extension with at least 1 lymph node and nodal disease. And look at how the curves separate. 83.1 versus 60.4 at 3-year mark, and the hazard ratio is very impressive. It's around 0.3, and all the subgroups have benefited. And these are the secondary endpoints, which are locoregional recurrences, distant recurrences, very substantial benefit. And this shows the toxicities, pretty manageable toxicities in line with our experience with immunotherapies these days. So here's the summary. Cemiplimab led to lower rates of locoregional recurrences, improved disease-free survival rates with a hazard ratio of 0.32, and lower rates of distant recurrences. So this has become the new standard of care. And just one slide I want to put up there is this study, which is a very similar trial, was also presented at ASCO where after this after the C-post. Shockingly, this trial was negative. And the one difference is, and this was basically using pembrolizumab. And I wanted to show the curves here. You see the subgroups just all over the place on either side of one. And overall survival was actually inferior in the pembrolizumab group. And we didn't quite understand why it was. But the big difference is the randomization was done 2 to 10 weeks after finish of radiation in the C-post trial, but in the Keynote 630 trial, the randomization was done 4 to 16 weeks after finish of radiation. So there was a delay in initiation after finish of radiation. So that may have played a role, but also there was a difference in the high risk categorization of high risk, where patients with recurrent skin squamous cell cancer were included. They have a very fixed definition in C-post, whereas a very loose definition in the Keynote trial that may have played a role where some low-risk patients may have been added and tested. And there was also a difference in the number of lymph nodes as a risk feature. Okay, I'm gonna probably stop, but I have these slides for you all. Can feel free to review. Thanks. Any questions?
Thank you very much, Dr. Khandra. Dr. Mike Driscoll serves as our director of the gastrointestinal oncology program at the Norton Cancer Institute, and he's involved in the gastrointestinal oncology clinical trials that we have, the multidisciplinary GI conferences and the multidisciplinary GI clinics. He's published multiple peer-reviewed articles on both science translational topics and clinical research. Dr. Driscoll graduated from Colorado State University with a degree in molecular biology, did his MD at Louisiana State University, did an internship at Tulane, and then did residency in internal medicine and a medical oncology fellowship in Louisville at the University of Louisville, presenting advances in treatment of gastroesophageal cancer, evolving standards and emergency therapies. Welcome, Dr. Driscoll.
Thanks, John. Appreciate that. It's 11 o'clock. We've been here for 3 hours. Everybody's ready to fall asleep, so if I can figure out how this thing works, too. Thank you so much. We've got a bunch of slides here, and I'm just going to go through them relatively quickly. I've got no disclosures. So as far as an overview here, we're going to talk about changes in neoadjuvant adjuvant treatment for localized GE junction gastroesophageal with curative intent, and then we're going to talk a little bit about some treatment changes, paradigm changes in palliative or metastatic disease. And with that, we'll talk a little bit about Dutch cross versus FLOT, ESOPEC, which was new data that recently published, a long-term update of Checkmate 577 and the Matterhorn trial. So this is a real busy slide. I don't know if we have a pointer here. We do, right here. So we're going to start top left here. This is sort of standard of care treatment. We see perioperative systemic treatment of FLOT, which is 5-FU, leucovorin, oxaliplatin, taxane, and then more recently updated with durvalumab from the Matterhorn study, which we'll talk about in a few minutes. We see lower kind of left, as we kind of go down here, perioperative chemoradiation consisting of weekly carbotaxol with radiation per the Dutch Cross study. Here in the United States, we tend to give more of a definitive chemoradiation dose. We'll talk about the radiation dose changes there in just a couple minutes. And then we'll also talk about, on the lower right-hand side, postoperative systemic treatment with nivolumab following combined chemoradiation and surgery, which is sort of the long-term update of Checkmate 577. Okay. So we've got two kind of main standard of care treatments here for gastroesophageal cancer. So we see on the top left the Dutch Cross. These folks in this trial were esophageal and GE junction cancers, so no gastric here. 75% were adenocarcinoma, so 25% squamous cell carcinomas. These were T1 to 3, lymph node positive. They were randomized to surgery up front versus combined chemoradiation followed by surgery. And what we see with Dutch Cross was that there was a significantly higher rate of R0 resection, also path-CR. Not going to have a path-CR if you go to surgery first, obviously, but I do want to point out here that squamous cell carcinomas have a pretty significantly high path-CR rate with just combined chemoradiation, nearly 50%. Excuse me, and then adenocarcinoma, you know, obviously lower at 23% here. And then moving on to FLOT4 study. So this combined both gastric and GE esophageal adenocarcinomas, so no squamous cell carcinomas here. I want to point out here that there were kind of higher grade disease, so T2 to 4 as well. And these folks were randomized to FLOT, which is 5-FU leucovorin oxaliplatin taxane versus epirubicin-based treatments, which was standard of care prior to FLOT. Epirubicin, as the oncologists know, pretty toxic regimens. So we looked at that, 2 months of treatment followed by surgery, followed by 2 more months of chemotherapy. And what we found here with the FLOT4 study was that there was a higher R0 resection rate versus the epirubicin-based treatment and a higher overall median survival. So this sort of established FLOT as standard of care and sort of negated us needing to treat with epirubicin. So the NeoAegis study was the first study that actually looked at both of these regimens in a head-to-head fashion. And what they did here was look at both esophageal and GE junction adenocarcinomas, so adenocarcinomas only, randomized to ECF or FLOT versus combined weekly chemoradiation with carbotaxol per the Dutch Cross, followed by surgery and then further chemotherapy. And what this study found here, if we can go over here, neoadjuvant chemoradiation showed higher response rates, higher levels of path-CR, R0 resection, and some considerations here, though this was a non-inferiority study. So I do want to point out here that only 14% received FLOT, so a lot of these people received epirubicin, whereas FLOT is considered a superior regimen. And then the path-CR rate, if we see here, pretty low as compared to historical numbers with the Dutch Cross, which was double that at 23%. But ultimately, this found that overall survival is unchanged. So the ESOPEC study, which was data that was just published at ASCO this year, they actually looked at FLOT. So we see here FLOT versus Dutch Cross. This was 4140 gray, which was sort of a lower dose than we tend to use here in the United States. We tend to use more of a definitive radiation dose of 50 gray. These were folks all with adenocarcinoma here, esophageal, excluded were squamous and gastric. And what we see here was that median overall survival was significantly improved with FLOT versus Dutch Cross. Some caveats to this study, however, kind of want to point out here. And the exclusion criteria, squamous was excluded. We have a higher response rate with squamous, so that may be contributing to this. If we look at this forest plot as well, it looks as though FLOT tended to benefit folks somewhat less in, let's say, folks who were older and also folks who were maybe node negative. So we're thinking that, you know, this is probably driven more so by, you know, more advanced disease or younger patients. Some other things that we want to point out. Chemoradiation compliance was fairly low. Only 67% of people actually completed combined chemoradiation, where we know that historically it tends to be quite a bit higher, closer to 95%. The chemoradiation dose that we use in this study was 4140, where we tend to use more 50-40 conventionally. This author thought there might not be a meaningful difference. I think our radiation oncology colleagues, if there's any in here, would probably argue otherwise. And then one of the biggest things I want to point out here is that immunotherapy was not received in the folks with the Dutch Cross study, which Checkmate 577 is now standard of care. Let's see. So we'll talk a little bit about Checkmate 577. So basically, here's the schema. So Checkmate 577, these were folks with stage 2 and 3 esophageal GE junction adeno or squamous. They were given neoadjuvant chemoradiation with carbotaxol with radiation. These folks all went to surgical resection. They needed to have an R0 resection and residual pathologic disease. So if the patients that had a complete response were excluded here. They were stratified based on histology, lymph node status, and PD-L1 expression. They were randomized in a 2-to-1 fashion to nivolumab versus placebo. And then the primary endpoints of disease-free survival and overall survival were observed. And this was kind of a long-term follow-up of 78 months. So this was the more recent data just published here at ASCO. So what we see here is the disease-free survival is in favor of nivolumab versus placebo in a long-term follow-up. We see that distant metastasis-free survival also favors nivolumab versus placebo as well. And that overall survival, even though this did not meet statistical significance, still favored nivolumab long-term. I do want to point out something here in the subgroup analysis. Really, as far as PD-L1 expression, if we see here on the forest plot, really matters. So we see here that folks that had less than 1% PD-L1 expression versus 1% or greater had pretty disparate results. And if we look at the curves here on the right-hand side, less than 1% PD-L1 actually favored placebo versus nivolumab. So obviously critically important to know PD-L1 status. I thought this was interesting. So per Checkmate 577, the investigators actually looked at PD-L1 expression, pre-tumor, pre-chemoradiation, and then actually looked at PD-L1 expression post. And it looked as though there was a 51% increase in PD-L1 expression after radiation in these folks, which kind of leads us to believe that maybe radiation might induce expression of PD-L1, which I thought was interesting. Moving on to the Matterhorn study. So the Matterhorn study, randomized phase 3 study of the addition of durvalumab to FLOT in resectable gastro and gastroesophageal cancers. We were actually part of this study. My PharmD liked to kind of put that slide in there. Anyway, so the Matterhorn, again, study population, gastric and GE junction, stage 2 to stage 4, and they were randomized basically in a 1-to-1 fashion to durvalumab plus FLOT plus placebo plus FLOT for 2 months, followed by surgery, followed by further treatment, and then basically a year of durvalumab. And primary endpoints were event-free survival, overall survival, and path-CR. As far as completion rates, fairly similar between the two arms. Baseline characteristics, a couple things I want to point out here. So we see here gastric was about 70% of the study, and GE junction about 30%, so it was largely a gastric study. Fairly significant number of T4 lesions as well, a lot of node positives here, and there were some folks with MSI high that were included in this study as well. We see here on the survival curves, event-free survival was statistically significant at 18 and 24 months in favor of addition of durvalumab. Key subgroups, a couple things I want to point out here as well, more so PD-L1 expression, where we look at that stratified by PD-L1 expression. Folks that have low PD-L1 expression did not seem to quite benefit as much, and also patients with diffuse histology did not seem to benefit quite as much. Primary endpoint of overall survival, while this did not reach the statistical significance, was still in favor of durvalumab plus FLOT. And as far as path-CRs, this was statistically significant. We see 7% path-CR, placebo plus FLOT, and then 19%, almost a tripling of path-CR. And then as far as secondary endpoint, disease-free survival, also in favor of durvalumab plus FLAUD. AEs were fairly similar between the groups, no increased safety signals. So as far as the conclusion here, Matterhorn does support a new global standard for perioperative durvalumab and FLAUD as a new standard of care. So one thing I do want to point out what we don't have. So we don't have data for Checkmate 577, which is combined chemoradiation followed by adjuvant durvalumab versus Matterhorn. So that would be an interesting study, and maybe that's something we can look at. I want to point out here, we're switching gears to kind of metastatic or palliative treatment. More so just kind of want to look at this as a timeline and more to kind of point out it's really critically important that we know what people's molecular status is before we treat them. If we see here back in 2010, 2010, the addition of trastuzumab to chemotherapy in the TOGA trial significantly improved response rates. Cyramza paclitaxel, which is now standard of care as far as second-line treatment or has been historically. Destiny Gastric, the addition of, second-line trastuzumab deruxtecan, which is an antibody-drug conjugate. And then pembrolizumab, nivolumab, adding to chemotherapy, immunotherapy, and also trastuzumab 2 in Keynote 811. Spotlight, so we were part of that trial as well. This is looking at Claudin 18.2 expression with the addition of zolbetuximab, which is a monoclonal antibody. So again, all of this stuff is really important to know what people's molecular status is up front prior to doing treatment on these folks. And going to talk a little bit here about the Destiny Gastric 4 study. So this was a large global phase 3 study looking at patient population in second line who were HER2 positive, who had already had progression on a trastuzumab-based treatment. They actually biopsied, found that they still had expression. They were randomized in a 1-to-1 fashion to trastuzumab deruxtecan versus Cyramza paclitaxel, which again would be standard of care. And they looked at primary endpoints of overall survival and some secondary endpoints as well. So as far as the primary endpoint of overall survival, this was met in favor of trastuzumab deruxtecan versus Cyramza paclitaxel. And this showed essentially a 30% reduction in risk of death with this drug. And as far as response rates, also in favor of trastuzumab deruxtecan versus standard of care Cyramza paclitaxel. AEs may be a little bit higher in the trastuzumab deruxtecan, which we have more experience with that now, so we're informed on how to handle that. So this basically is now showing us that really in these folks that have continued HER2 expression beyond progression with first-line HER2, we really should be using trastuzumab deruxtecan in these folks. And that's it. And this is my team, right over there. Couldn't do what I do every day without them. Just want to thank them too. And that's it. Any questions?
So you mentioned the head-to-head between Cross versus FLAUD, and it seems like the SOPEC kind of showed some superiority with FLAUD, but lots of
Caveats.
issues with the study. So what factors with patient situations impact your decision to treat with Cross versus FLAUD?
Sure. So folks who have squamous, I think that's kind of a no-brainer. So, 50% complete pathologic response with those folks. So anyone who's squamous, we ought to be going with that. Folks that maybe don't have quite as advanced disease, we would probably go more with the Dutch cross with the higher radiation dose rather than FLAUD. So something that's maybe not quite as advanced, higher T stage, higher N stage, we would probably go more with Dutch cross rather than the FLAUD.
Thank you.
Yeah. Okay, thank you.
Thank you very much, Dr. Driscoll. Douglas Nelson is a medical oncologist, hematologist, who received his medical degree from the Uniformed Services University at Health Services, Bethesda, Maryland. He did a residency in internal medicine and his fellowship in hematology oncology at Wilford Hall in Texas. He spent the early part of his medical career in the military service. He left the Air Force as a lieutenant colonel in 2009. While he was in the Air Force, he served doing multiple clinical trials as part of their trial system. When he left the Air Force, he went to Houston, where he joined the University of Texas MD Anderson Cancer Center, working at their Woodlands office, and he served as their medical director at the Woodlands office. Presenting advances in hepatocellular cancer therapy, Dr. Doug Nelson. Doug.
Well, thanks. I'm acutely aware of the fact that I'm the one thing between you and lunch, so we'll try to get going here. See if I can figure it out. Okay. I was asked to talk about advances in hepatocellular carcinoma, and unfortunately, 2025 has not been that exciting of a year in HCC. So we're going to do a bonus of advances in hepatocellular carcinoma and colorectal cancer because it was a much more impactful year in our practice for colorectal cancer, and I definitely want to be able to share some of that information with you. Okay, so starting with hepatocellular carcinoma, this is a staging system called the BCLC, or it's Barcelona Liver Clinic. Unfortunately, NCCN has not been as useful in defining optimal treatments in hepatocellular cancer as it in liver cancer, as in HCC. It's not been as useful as it has for other cancers. So we do have this BCLC system, which is used very widely throughout the world. And it incorporates some of the important features that play an impact on how we make our choices. Because in HCC, even more so than a lot of other cancers, we're really dealing with two major problems, one of which is the cancer, but the other is that most of these patients have cirrhosis, and some of them have fairly advanced cirrhosis, and that has a major impact on their liver function and what they will tolerate in terms of treatment. And so that is incorporated to some extent here. Just as a general statement, what you'll see is that the treatments for HCC, and there are a lot of them, but they are broadly divided. Down here on the left is just local regional treatment, so local treatments. So can you resect a liver tumor? Can you ablate a liver tumor? Can you do therapies like Y90 or TACE, transarterial chemoembolization? Can you do a liver transplant? So those are all what I would call local therapies. And then traditionally, reserved for more advanced disease is systemic therapy. And so that's a starting point for kind of where we are now, and not to go through any of these in great detail. But when we talk about systemic therapy, which is traditionally the province of medical oncology, for advanced HCC, we have two current standards for most patients. For patients, as long as they are eligible to receive immunotherapy, then they will get an immunotherapy-based regimen. We know that traditional chemotherapy just doesn't work very well in this cancer, and we don't use traditional chemotherapy for HCC. So one study was the IMbrave 150 study, looking at the combination of atezolizumab and bevacizumab, showing a clear survival benefit, with a median survival with the combination of atezo-bev of 19 months. And that was compared to sorafenib, which for about 10 years was all we had. So a targeted therapy, tyrosine kinase inhibitor, sorafenib, and atezo-bev was clearly better, and that's one standard. A little bit later than that came along the Himalaya trial with the combination, so combo immunotherapy with durvalumab and tremelimumab, and that also, compared to sorafenib, had a survival benefit. And one of the things that has come out of that trial over time is is actually a very impressive number of about a 20% 5-year survival, which is certainly far better than what we have historically seen. So that's kind of where things have been. That's not new this year. That's been the way it's been for a few years now. So one new thing this year was kind of an add-on to that as an option. So the Checkmate 9DW study, which is looking at the combination of ipilimumab and nivolumab, a fairly common regimen that's been looked at in a variety of cancers, and now also it has been looked at previously in more advanced second and third line, but this is now looking at it in first line for HCC. Once again, compared to tyrosine kinase inhibitor with either lenvatinib or sorafenib, and again, showing superiority, so a survival benefit. And so this now is a third potential additional first-line option. And so that's one thing that's new. I told you there's not a lot new in HCC this year, but that's one thing that's new, is to have this available as a first-line option. The other thing that I'll just very briefly kind of tell you about where we're trying to head in the field is this idea of the traditional province of medical oncology, systemic treatment. Instead of just using that for patients that are at metastatic, clearly have extrahepatic disease, more advanced disease, is there a way to move that forward and then in some cases potentially combine it with the local treatments? So this was one study basically looking at that same regimen that we commonly use in advanced disease, the atezolizumab and bevacizumab, and trying to use it in the adjuvant setting for high-risk patients that have been resected. There was some signal for this with a relapse-free survival benefit early on, but unfortunately you can see those curves come together, and then from a survival standpoint, there just doesn't seem to be a clear survival benefit. And so right now, that's just not something that we would consider a standard option. Another way to try to go about this is to take a regional treatment like TACE, transarterial chemoembolization, and add to that. So this trial, the Emerald 1, looked at taking TACE and either adding single agent durvalumab or the combination of durvalumab and bevacizumab. And this study had an improvement in progression-free survival. However, again, so far has demonstrated no evidence of a survival benefit. And right now, we really are still searching for that improvement in survival, and to put patients on additional systemic therapy for 6 months, 12 months, 18 months, but if you aren't actually improving how long they live, we really have to question whether that's the way to go. So we're still searching for ways to actually cure more patients and give them a survival benefit. So this is where we are on the NCCN guidelines right now with HCC. So they list the preferred regimens as, the two that I had told you are already well established, atezolizumab and bevacizumab, and tremelimumab and durvalumab. And then as other recommended initial regimens, the TKIs like lenvatinib and sorafenib, they're still there mainly for patients that for one reason or another have a contraindication to immunotherapy, which is not very many patients, but there are a few. And then again, nivolumab and ipilimumab is now in there as a first-line option. Okay, so I'm gonna shift gears to colorectal cancer because there was quite a bit going on in colorectal cancer this year, and I think some very exciting information. I'm going to point out something to you that I think is very important to keep in mind. A lot has been made in the last few years of the fact that we are seeing a large jump in the incidence of colorectal cancer in the younger patient population. So the under 50 population, we are seeing a lot more patients. Not really in the over 50 population, but the under 50 population. And, several years back now, the American Cancer Society and all the accepted standard groups have recommended lowering the screening age for colon cancer from 50 down to 45 for this reason. And this is data from the American Cancer Society. So just focusing here on this younger population, in the 20 to 39 and 40 to 49-year-old age group. Unfortunately, we still see lots of young women with breast cancer, but right behind it is colorectal cancer as a leading cause of death. It's already the leading cause of death in younger men, and it is projected in the next few years to be the leading cause of cancer-related death for that adult under 50 population. So a real problem, and we certainly need to do better. So here were several studies that were presented at our recent ASCO meeting in June. The first is the breakwater study. So this looks at a specific group of patients that have this BRAF V600E mutation. That's about 8 to 12% of patients. And we have BRAF targeted therapy. That came along and first was a success in melanoma, and now, has also been extended to a colorectal cancer. But what we found is that just by itself, it was not very effective in colon cancer. So we combined it with other drugs. Specifically, we combine it with either MEK inhibitors or EGFR inhibitors. And so this was the precursor trial, which was Beacon. And Beacon was a second-line and third-line trial in patients with this mutation, comparing it to standard treatment options for chemotherapy and clearly showing superiority in overall survival. So for a while, and this was a three-arm trial, really the binimetinib, the survival turned out to be about the same, whether you included that or not. So for several years now, encorafenib cetuximab has been a standard option for second-line and beyond treatment for BRAF V600E mutated colorectal cancer. So the new trial is Breakwater, which, as we often do when we have success in later line therapy, we move it up. So this is now first-line therapy, and this was a three-arm trial comparing encorafenib cetuximab to the combination with chemotherapy to standard of care chemotherapy. First-line metastatic colon cancer. This did not include MSI high patients, so some patients with BRAF 600E are also MSI high, and for those patients, immunotherapy is the standard treatment. But this trial, just to kind of cut to the chase, was clearly a strongly positive study for progression-free survival and for overall survival. And, you could drive a semi through those two lines. There's a very large difference. It doubled overall survival from 15 to 30 months. And you can see 15 months for standard treatment. We really needed to do better with BRAF V600E mutated cancer. That historically has had a very poor prognosis. It's a difficult disease to treat, and these kind of survivals with standard chemo of 15 months, when most of our current clinical trials in advanced colon cancer are showing survivals of 3 years, 2.5 to 3 years. It tells you we needed to do better, and now we are. So now we're getting survivals that are very close to what we get in non-BRAF mutated cancer. So, and even the EC alone, so even targeted therapy alone did better than chemo. So I would say that the new standard in first-line treatment is encorafenib and cetuximab plus FOLFOX. If for some reason they're a poor candidate for the chemo part, you can actually do very well with just targeted therapy. That's breakwater. Just one last slide showing, as you might expect, a very nice improvement in response rate as well. Okay. And just NCCN guidelines, this change is now reflected in the NCCN guidelines. So next, moving on. Now we're talking about stage 3 colon cancer, and this trial is ATOMIC. This was a cooperative group trial, and for many, many years, forever, the standard of care for stage 3 colon cancer has been FOLFOX. So if we go back to 2004, 2005, when oxaliplatin was approved for this setting, that has been the standard of care. However, we also know that immunotherapy works very well for patients that have advanced colon cancer that is MSI high or MMR, mismatch repair deficient. So can we move that into the adjuvant setting? This is just a couple of slides showing how well immunotherapy works in advanced metastatic disease that's MSI high. Again, you can just see the very impressive separations of these curves. And so immunotherapy has been the standard initial treatment for these patients with metastatic disease for several years now. So now we're looking at adjuvant therapy. So adjuvant therapy, we've got here in the ATOMIC design, standard FOLFOX, which at the time this trial was designed, everybody got 6 months. Now some patients get only 3 months. And it was comparing standard FOLFOX versus FOLFOX plus atezolizumab for these patients that were MMR deficient. You can see the superiority in terms of disease-free survival there. And so this was and let me go back just to point out this hazard ratio of 0.5. So there's not a lot of trials that do that well. So it had a 50% reduction in the risk of recurrence of colorectal cancer by adding an immunotherapy agent. And I would say that definitely implies that we should be doing that on a routine basis. There's still a lot of questions about exactly how to do that because of a variety of things, including the fact that 6 months of FOLFOX is no longer the universal standard in the stage 3 setting. So this is, again, now reflected in the NCCN guidelines. And then here's some questions. You do so well with immunotherapy, do you even need chemo? We don't know that. This was given as adjuvant therapy, but there have been some very impressive results noted with even just a month or two of immunotherapy in the neoadjuvant setting, where you can get rates of pathologic CR, no cancer remaining, of about 60% with just 6 weeks of immunotherapy in the adjuvant setting. So should we be giving this as adjuvant or should we just be giving it as neoadjuvant? Can we use circulating tumor DNA to better select patients? Should we be doing single or doublet? So again, pembrolizumab has been used, the nivolumab and IPI combo has been used. Atezolizumab was in the ATOMIC trial. But should we be doing single or doublet immunotherapy, and how long do we really need to do it? In this trial, everybody got immunotherapy for a year, but I just said that you can get 60% path CR rates with a couple of months in the neoadjuvant setting. So do we really need to do it for a year? Lots of unanswered questions, but an exciting development. And again, in the stage 3 setting, that's 15% of your patients. So it's not 1 or 2%. It's a pretty big chunk of patients. All right, the Alaska trial. So Alaska looks at PIK3CA mutations. And there has been evidence in the past, mostly retrospective, that patients who get aspirin appear to have a significant benefit in terms of reduced risk of colon cancer recurrence, and even mortality by the use of aspirin in the adjuvant setting. This is old data, but it's also retrospective, and so it's been one of those things that's kind of been out there, and some people did it, some people didn't. Not a standard recommendation, not a standard thing to do, because we lacked randomized controlled trial data. So now we do have randomized controlled trial data. So this was randomized use of aspirin versus placebo, 160 milligrams, so 2 baby aspirins a day for 3 years in the adjuvant setting for colon cancer, stage 2, stage 3 colon cancer, and clearly showing a benefit in terms of colorectal cancer recurrence. This now again is made it into the NCCN guidelines. So now, standard recommendation that, and this is a change for us. We didn't usually feel like we had to do NGS profiling in the adjuvant setting. The only time you really had to do NGS profiling was in a patient with metastatic disease. Now you have to do NGS profiling in the adjuvant setting because if they have a PIK3CA mutation, then they should receive aspirin for its proven benefit. Last trial, challenge. Very exciting, non-drug treatment. So this was actually a formal trial of structured exercise, high-risk stage 2 and stage 3 patients. And I won't go into it in too much detail, but basically stage 2, stage 3, completed adjuvant therapy, and they got randomized to either structured exercise or they just got health education material, but they didn't get the structured exercise program. The structured exercise program was pretty intense. The goal was to increase their level of activity by 10 MET hours per week, which really is about, say, 2.5 hours a week of exercise. This lasted 36 months, and the benefits were pretty impressive. So a 6% improvement in disease-free survival with reductions not only in colon cancer recurrence, especially in the liver, but also impressive reductions in new primary cancers, and a 7% difference in overall survival. That is easily on par with anything we've done from a drug standpoint. And this is completely non-pharmacologic therapy. So this is certainly something that we should be talking about with our patients. Patients a lot of times ask what they can do, and as opposed to what we do for them, and this is certainly something that they can do. And so that's all I have. I'll be happy to take any questions. Yeah, Jason.
With the increase in the young patients that are experiencing colon cancer and with the data you just showed from the challenge trial, do we think that that increase in the younger population is mainly due to the obesity epidemic? Or do we think there are other risk factors that have that necessity?
That's a good question. I don't know. I don't think anybody knows exactly why we're seeing this increase in the younger patient populations. A couple of theories I've heard is maybe it's related to changes in the gut flora with widespread antibiotic use. That's one possibility. Other possibilities is changes in our diet over time, which kind of is related to the obesity epidemic, but just increased highly processed foods, increased chemicals in foods, but I don't think anybody really knows.
Quick question. If cirrhosis is such a high risk factor for HCC, and are there identifiable circumstances in cirrhosis that may be such high risk that patients could be considered appropriate for potentially like preventive use with something like Opdivo or something like that, a drug that's otherwise remarkably well tolerated? Have you seen any kind of conversation or discussions about something like that in these patients?
No, I've never seen any discussions of, preventative or prophylactic pharmacologic therapy. There is, however, fairly well-established screening guidelines for patients that are at high risk. And I think a lot of patients with cirrhosis don't get that screening, but there are, between, ultrasound and AFP, there are well-established screening guidelines. And so I think that's where, we can do better, is trying to identify these as early as possible. The earlier you find it, the better your options are. Yeah, Joe.
So this is great. One thing that the last thing you talked about, I recall an older study in breast that showed a similar decrease in survival of 7% with exercise. It seems like for everyone in this room, it's something easy to tell your patients to do and encourage them. It seems like, I don't know your thoughts, or has that changed your look at colorectal cancer?
I think that we've kind of generally promoted exercise, but to have an actual randomized study, that's the kind of high-level data that I think we've just been lacking. And so, that's a first. And of course, the study wouldn't have been done in the United States. This was mainly Canada that did this study. And even them, it took them a long time to do it. Thanks.
Thank you very much, Doug. I'd like to point out there are a lot of things besides cancer chemotherapy that help improve survival, and that's a good example. As Mo had a result this past weekend that getting your flu and COVID vaccine dramatically improves your survival for cancer patients.